Welcome to this deep dive. Today we're tackling a really practical and fascinating source.
Yes, it's a guide designed for pharmacists, all about managing common illnesses and, prevention right there in the pharmacy.
Think of this as getting an insider's look, really, at how your local pharmacy is changing.
And how they can be, well, often your first stop for a whole range of everyday health questions and issues.
So our mission today, to really unpack this source, we want to pull out the absolute key insights.
Those surprising facts, maybe.
Yeah, and the truly practical knowledge that shows you just how much your pharmacist can do. It's more than just dispensing, isn't it?
Oh, absolutely. We're aiming to give you the essential nuggets from this guide.
Sort of shortcut to understanding this vital and definitely changing part of your healthcare.
Precisely.
Okay, let's jump right in because, as you said, the role of the pharmacist is changing quite dramatically.
It really is. And one of the big shifts this guide highlights is the increasing number of patients being referred directly to pharmacies.
Not just from GPs.
No, not just from general practice, but also from services like NHS 111. It's becoming much more integrated.
And the NHS itself is kind of pushing for this too, encouraging people to buy over-the-counter medicines for minor things.
That's right. Instead of going for a prescription every time for something you can manage yourself.
Which puts a lot more emphasis on the pharmacist's professional judgment.
Exactly. And for their regular customers, they have the patient medication records, the PMR. That gives them a really valuable history.
So they know your background, your other meds.
Which means they might need, less extensive questioning than with someone walking in for the first time.
Where they really need to build that full picture from scratch.
Precisely. And it also means handling some sensitive situations sometimes.
Like?
Well, the guide touches on navigating requests when someone asks for a medicine. Maybe a friend recommended it.
Right.
But it's actually something that needs a GP prescription, or it's, outside the pharmacy's legal license to supply over the counter.
That needs careful handling. Tactful communication.
Ooh, very careful, professional communication. And then there's the whole pharmacy first development. That's huge.
Allowing pharmacists to supply antibiotics for certain conditions.
Yes, using patient group directions or PGDs.
Right, PGDs. So that's like a pre-agreed protocol.
Exactly. It allows pharmacists to supply specific medicines to specific groups of patients without an individual prescription, but they have to follow strict written rules.
But the guide stresses being cautious here, too.
Oh, absolutely. Handling these requests carefully, explaining really clearly when a patient doesn't meet the specific criteria, or maybe their condition falls outside the scope of pharmacy first.
And pharmacists are used to doing this anyway, right? Explaining why something can't be supplied over the counter.
Yes, they have plenty of experience explaining why something might need a doctor's visit, even outside of this specific service. It's all about safety and appropriate care.
Thinking about those conversations, the guide really emphasizes communication skills, especially for antimicrobial stewardship.
Oh, it's critical. Making sure antibiotics are used wisely. Improving that dialogue is absolutely key, particularly for things like, coughs and colds, respiratory infections.
Because often people expect antibiotics for those.
Exactly. The source makes a really powerful point here. Antibiotic use often has more to do with people's historical beliefs or expectations
than the actual clinical need.
Precisely. It's not always about what the infection needs, but what the person thinks they need.
And the guide points out that health literacy, sort of people's understanding around infections and antibiotics, really varies.
It does, hugely. There's a national survey mentioned. It found that certain groups, maybe based on social grades, some ethnic backgrounds, education level, even age, younger groups sometimes.
Well, less understanding.
Significantly less understanding about antibiotics and resistance. And what's really fascinating and concerning is that this correlates with higher antibiotic use in more deprived areas.
Wow. That's a major public health challenge.
And the pharmacy team is right there on the front lines dealing with it.
There's also that insight about the mismatch, what the healthcare worker thinks the patient wants.
Often assuming it's an antibiotic.
Versus what they actually want.
Absolutely. What they might really want could be much simpler. To feel heard, To
be taken seriously. Examined, maybe.
Yes, and to get a clear, reasoned explanation for why an antibiotic isn't the right thing this time. Plus, importantly, being offered effective alternatives for symptom relief.
So practical communication strategies become vital. The guide suggests things like asking directly about concerns.
Yes, open questions like, what are the things you are most worried about? Really getting to the heart of their anxiety.
And showing empathy. That sounds crucial.
It makes a huge difference. Even simple things like, you sound miserable, how are you holding up? It builds rapport, builds trust.
I like this idea mentioned of a no-problem commentary during the consultation.
Yes, sort of normalizing common symptoms.
Like saying, that fever, that's actually a good sign your body's fighting the infection.
Or green phlegm, surprisingly, can still be viral. Or maybe, just so you know, sinusitis can sometimes hang around for 2 or 3 weeks, even viral ones.
It manages expectations, doesn't it? And educates subtly.
Exactly. And the guide also suggests using nationally recommended diagnostic criteria or scoring systems.
And telling the patient you're using them.
Yes. Explaining to the patient that these tools help guide the decision about whether an antibiotic is actually likely to help them. It makes the process transparent.
Okay, let's get into the heart of it then, managing those common illnesses, starting with the ones everyone gets. Respiratory problems. Coughs, colds, flu, sinusitis.
Right. Most coughs a pharmacist sees are down to viral respiratory infections, often coming along with cold symptoms.
And the guide notes something people find surprising, that coughs can linger.
Yeah, for several weeks sometimes. It's simply because the airways, they take time to heal after the infection's gone. Damage has been done.
And cough medicines, suppressants, expectorants.
Yeah.
The evidence isn't amazing.
It's pretty limited, scientifically speaking. But that said, some people do find them helpful, comforting even, so pharmacists can advise on using them appropriately.
For younger kids under 6, it mentions simple things.
Yes, demulcents are favored, things like glycerol or just a simple lemon and honey drink. It's about soothing that throat irritation.
Now here's where the source gets really interesting. Honey.
Yes. A systematic review found some indication. Now, the evidence isn't top tier, we should say, but it suggested honey may be more effective than placebo, or even some OTCs, for acute cough symptom relief.
Wow. And NICE recommends it.
Yes. NICE actually recommends honey as a self-care option, often suggesting making a drink with honey and lemon.
But there are important warnings.
Crucial warnings. No hot drinks for small children, obviously, and absolutely no honey for children under 1 year old.
Why is that?
Because of the risk, albeit it's small, of infant botulism. Very important.
Good reminder. Okay, nasal decongestants, another big seller.
Yes. The guide highlights the difference between topical drops or sprays and oral ones.
Topical ones can cause rebound congestion.
That's the one. Use them for too long and your nose gets blocked because of the spray. Oral decongestants don't have that specific issue.
And some last longer than others.
Yes. The guide notes oxymetazoline and xylometazoline generally have a longer duration of action.
And there are age limits for kids.
Definitely. MHRA advice is clear. Okay for ages 6 to 12, but for no more than 5 days maximum, and not to be used at all in children under 6.
Moving on to flu. The guide flags the risk of complications, like pneumonia.
Especially in vulnerable groups, pharmacists need to be really watchful here.
Who are the higher risk groups?
Well, young babies, the very old or frail, anyone with pre-existing heart or respiratory conditions, pregnant women, people with kidney disease, weakened immune systems, or diabetes. It's quite a list.
And antibiotics should be saved for those serious complications.
Absolutely reserved for those cases, to preserve their effectiveness when they're really needed.
What are the warning signs for urgent referral then? If flu seems to be getting complicated.
Things like a really severe or very productive cough, a fever that just won't break, chest pain that's worse when breathing in pleuritic pain, or any confusion or delirium, those need checking out urgently.
The case example mentioned, Mrs. Allen asking about her husband with heart issues. That illustrates the point well.
Perfectly. It emphasizes checking his PMR, his medication record, for potential interactions with cold remedies.
And asking really careful questions about his specific symptoms, his existing health problems.
Exactly. It's not just about the cold, it's about the whole person. There are other health factors, the potential risks.
That individual patient context is so key.
Okay, sinusitis. What symptoms does the guide highlight?
Usually it's nasal blockage or discharge, plus facial pain or headache.
Right.
Or in adults, a reduced sense of smell. Or in children, sometimes just a persistent cough.
And most cases are viral, like a cold that drags on.
Yes, most are viral.
So what might suggest it's tipped over into a bacterial infection that might need antibiotics? Key things to look for are a marked worsening after initially seeming to improve, sometimes called double sickening.
Okay.
A persistent high fever, say over 38 Celsius, thick colored nasal discharge that isn't clearing up, or severe pain just on one side of the face, especially if it feels like tooth or jaw pain.
The guide also mentions pharmacists and GPs working together on this.
Yes, having a consistent approach to managing sinusitis helps avoid confusing patients. They get the same poor advice whether they see the pharmacist or the doctor.
And that Dillip case, the 4-year-old with the night cough.
A great example of when referral is sensible. A persistent cough, especially mainly at night in a child, could be a sign of asthma, even without obvious wheezing.
Or just ongoing irritation.
Could be ongoing bronchial irritation after a virus, particularly if there's a family history of atopy and, asthma, eczema, hay fever. It raises the index of suspicion.
That family history flag is important.
Yep.
Okay, shifting gears to common gut problems.
Mm-hmm.
Mouth ulcers, most people get them occasionally.
Yes, the guide describes different types, minor and major aphthous ulcers, which heal differently. And sometimes, though less common, they can hint at a wider systemic condition.
What about treatments? Anything interesting there?
Well, it mentions considering vitamin B12 supplements based on BNF advice, even without proven deficiency. Also, physical barrier sprays and gels.
Like hyaluronic acid gels.
Yes, those show some promise according to the guide, though the evidence isn't totally conclusive yet.
Indigestion and heartburn. Super common. OTC options are available now.
Yes, proton pump inhibitors, PPIs like esomeprazole, omeprazole, pantoprazole, available over-the-counter for adults 18 plus for frequent heartburn or reflux symptoms.
How do they work again?
They work by suppressing stomach acid production, blocking the proton pump. But a key thing the guide notes is they might take a day or so for the full effect.
So you might still need an antacid for quick relief initially.
Exactly,
Yeah.
in the short term.
Now, here's a really critical point from the source. The link between certain common medicines and stomach problems.
Yes, hugely important. NSAIDs, non-steroidal anti-inflammatories like ibuprofen, also aspirin, and clopidogrel.
They're strongly linked to causing indigestion, stomach ulcers, and even bleeding risk.
Absolutely. They interfere with the stomach's natural protective mechanisms, and elderly patients are particularly vulnerable to these side effects.
So if someone's taking one of those and gets new or bad indigestion,
That's a major red flag for referral back to their GP. Definitely.
the guide lists quite a few other red flags for indigestion too.
Yes, things like first-time symptoms if you're over 55, if it's linked to those drugs we just mentioned, pain that's persistent, recurrent, or severe,
Any blood.
any sign of blood in vomit or stool, pain that comes on with effort or activity, persistent nausea or vomiting, if OTC treatment hasn't worked, suspected side effects, unexplained weight loss, or if it's a child experiencing these symptoms.
That's a comprehensive checklist the pharmacist is running through mentally.
It is. Referral ensures potentially serious underlying causes aren't missed. Okay, constipation. The guide offers some reassurance here.
That it's rarely caused by serious bowel conditions.
In most people presenting with new onset constipation, yes, serious underlying causes are less common, but lots of drugs can cause it.
Ah, yes. The medication review aspect. Like what?
Things like opioid painkillers, some antacids with aluminium, antimuscarinic drugs used for various things, some anticonvulsants, certain antidepressants. The list is quite long.
And the guide mentions a potential issue with overusing stimulant laxatives.
Yes, a potential vicious circle. Using them too often might, over time, damage nerves in the colon, actually making constipation worse.
And there's a concern with misuse.
Yes, particularly in the context of dieting or eating disorders. Pharmacists might pick up on problematic purchasing patterns and can offer sensitive advice.
Lifestyle advice is important too. Caffeine.
Can stimulate bowel movements, but it can also dehydrate, so avoiding excessive intake is wise.
And simple things like toilet routine.
Yeah, not delaying when you feel the urge to go. And posture, even just raising your knees slightly, maybe using a low stool, might help some people.
The case of Mr. Dabrowski is interesting constipation after losing his job.
Yes, it links his symptoms not just to lifestyle changes, but potentially to depression.
Because depression itself can cause constipation.
Independently of medication, yes. So the guide suggests asking about other symptoms like sleep or appetite changes, which might point towards needing a depression assessment by the GP.
Shows that holistic view again. Diarrhea next. Common causes are often bugs.
Often infectious, yeah. Campylobacter, salmonella linked to hygiene or food handling. Bacillus cereus from improperly stored reheated food, like rice sometimes. Good hygiene is key prevention.
But persistent or chronic diarrhea needs checking out.
Definitely needs referral. Could be IBS, a tumor, inflammation like Crohn's or colitis, or problems absorbing nutrients.
And antibiotic-associated diarrhea.
Very common. Affects about 1 in 10 people taking antibiotics. A significant proportion of the severe cases are caused by C. diff Clostridioides difficile.
How does that happen?
Antibiotics disrupt the normal, healthy gut bacteria, allowing C. diff, which might be present in small numbers, to flourish and produce toxins that damage the bowel lining.
Yeah, it spreads easily.
Primarily through poor hygiene, unfortunately. Spores can contaminate surfaces. Hand washing is absolutely crucial, especially in healthcare settings, but also at home.
For managing fluid loss, oral rehydration solution, ORS, is the go-to.
Essential. The guide gives advice on volumes for different ages and stresses, giving small amounts frequently, especially if someone's vomiting.
And avoid fruit juice and fizzy drinks.
Strongly advises against them. They can actually draw more fluid into the bowel and make diarrhea worse because of their high sugar content.
What about loperamide, the anti-diarrhea medication?
It can be effective for short-term relief in older children and adults. Over the counter, it's for a maximum of 2 days use, and you must drink extra fluids alongside it.
Are there times you shouldn't use it OTC?
Yes, important contraindications, not for children under 12. And not if there are signs suggesting something more serious is going on, like bloody diarrhea, a high fever, or severe abdominal pain. That needs investigating.
The Mrs. Very case, preparing for holiday tummy.
Good example. Loperamide is suitable for her husband, the 14-year-old, but ORS is needed for the 10-year-old, and it reinforces that vital travel hygiene advice: bottled water, well-cooked food.
And then the Mr. Radcliffe case, elderly man, diarrhea after antibiotics.
Immediately flags potential C. diff. Given his age, frailty, other meds like digoxin and furosemide, which dehydration can really mess with, immediate referral is the right call.
Okay, irritable bowel syndrome, IBS. Affects lots of people.
Usually starts in young adults, 20s, 30s, affects about twice as many women as men.
Key symptoms.
Abdominal pain, often easing after opening bowels. Bloating is very common. And altered bowel habit could be constipation, diarrhea, or alternating between the two.
But if an older person gets these symptoms for the first time,
referral is needed to rule out other potential causes. IBS is usually diagnosed younger.
Dietary advice can help.
Yes, things like oats and linseeds might help with wind and bloating for some people. The guide mentions the low FODMAD diet.
That complex one.
Yes, it should really only be done under the supervision of a trained dietitian, as Nystec Nemens. It's quite restrictive.
What about managing IBS symptoms?
Bulking agents like ispaghula husk can help some, mainly with constipation, but they take time to work and you need to drink plenty of fluid. Finding the right dose can take weeks.
Antispasmodics,
like hyoscine butyl bromide, can help with pain and cramping, but they have anticholinergic side effects, dry mouth, constipation, etc., and potential interactions. Need caution, especially in older people.
Loperamide again?
Only for occasional use for diarrhea flare-ups or urgency. It generally doesn't help the pain or bloating much.
And probiotics.
The guide notes some evidence, particularly for diarrhea associated with antibiotics, or maybe IBS triggered after a bout of gastroenteritis, but it's not a guaranteed fix.
The Jane Abera case sounds complex. Known IBS, but new symptoms.
Yes. Young woman, history of IBS, but now getting upper abdominal pain after eating. Urinary frequency, plus constipation, bloating, stress. It shows why referral can be useful. To confirm it is just IBS. Address the stress component, discuss diet properly, maybe try different medication approaches.
Makes sense. And finally, briefly, hemorrhoids or piles.
Common symptoms: itching, irritation, maybe pain, sometimes a swelling or lump that might prolapse, meaning it comes down.
Management is usually lifestyle first.
Increase fiber, drink more fluids, then suppositories or creams for symptom relief.
The Kieran Shaw case, regular customer, holiday trigger.
Yeah, highlights how a pharmacist can manage a known recurring issue. Holiday diet change likely triggered his symptoms: itching, irritation, small reducible prolapse. Recommending appropriate treatment is standard practice.
Okay, let's switch to skin conditions, another huge area for pharmacy advice: eczema and dermatitis, often used interchangeably.
Pretty much, though dermatitis is perhaps used more when there's a clear external cause suspected, like contact dermatitis.
Atopic eczema is the common childhood type.
Very common, often improves with age. Strongly linked to that atopy family history, asthma, hay fever, eczema.
And it can be triggered or worsened by things applied to the skin.
Yes, sensitivities can develop to all sorts of things in creams and ointments, local anesthetics, some antihistamines, antibiotics, antiseptics, preservatives, even lanolin in some emollients.
When does eczema need referral?
Urgently if there's suspected infection. Look for spreading redness, swelling, pus, maybe weeping, or if the person has a fever.
Like the Aisha Shaw case in the guide.
Exactly. A child with worsening eczema highlights the potential need for a skin swab by the GP and maybe oral antibiotics alongside the usual creams, which requires a prescription.
And the cornerstone of OTC treatment is emollients.
Absolutely key. Moisturizers. Using them generically and frequently is the foundation of managing eczema.
Topical steroids like hydrocortisone are available OTC, but with limits.
Very limited indications over the counter. Age limits usually 10 plus for hydrocortisone OTC. Maximum 1-week course. And crucial contraindications shouldn't be used on infected skin, acne, or sensitive areas like the face or anogenital region without specific medical advice.
The guide has a strong warning about complementary therapies for eczema.
Particularly Chinese herbal medicines. It states there's insufficient evidence they work, and worse, they've been associated with serious adverse effects.
Like what?
Some have been found illegally contaminated with potent prescription corticosteroids or even harmful bacteria like MRSA. Definitely an area for extreme caution and advising patients about the risks.
Okay, acne. Very common, affects face, back, chest.
Yes, face mostly, but upper back and shoulders in about half, chest in maybe 15%. OTC treatments aim to, remove plugs from pores and reduce bacteria.
Formulations matter.
Yes, gels, especially those with an alcohol base, can be quite irritating and drying. The guide also notes there's actually limited evidence for some popular ingredients like topical nicotinamide or antiseptic washes. Pharmacists should guide towards evidence-based options.
Athlete's foot, that's fungal.
Tinea pedis, yes, fungal. Often starts between the 4th and 5th toes. A key point is the risk of secondary bacterial infection.
What does that look like?
Weeping, pus, maybe yellow crusts. That needs referral for likely antibiotics.
Otherwise, OTC antifungals are the way to go.
Yes. Things like terbinafine or imidazole creams are usually effective.
Related to that is ringworm.
Tinea corporis,
Yeah.
also fungal, causes those characteristic circular red scaly lesions, often caught from infected people or animals like pets. Topical imidazoles work well. Advising on washing towels closed separately is important too.
Cold sores, usually manageable.
Usually, yes, caused by the herpes simplex virus. But referral is needed if they're very severe or widespread, especially concerning in someone with atopic eczema. It can spread rapidly and become serious, even life-threatening eczema herpeticum, or if the patient is immunocompromised.
Hyperhidrosis, excessive sweating.
Can be really embarrassing, though not medically serious usually. The primary focal type has no underlying cause, often starts young adulthood, affects specific areas like armpits, palms, soles. Triggers can include anxiety, emotion, spicy food, heat. Management is mainly reassurance and effective antiperspirants.
Warts and verrucae caused by HPV.
Yes, human papillomavirus. Very common, especially in children. They often disappear on their own as immunity develops, but it can take months or years. OTC treatments are available, but correct application is crucial for them to work, so pharmacist advice is key.
Insect bites and stings, usually mild.
Mostly. Bites cause itchy lumps from the insect saliva. Stings are usually more painful and swollen due to venom.
Red flags for infected bites needing referral.
Spreading redness or swelling around the bite, any pus, or if the person develops a fever. Pharmacy first criteria also allow antibiotic supply for certain infected bites meeting specific requirements.
Scabies caused by a mite. Sounds unpleasant.
It is intensely itchy. Causes a rash, sometimes visible burrows where the mite has tunneled, though these are often scratched away. Important point. It can affect the head and face in very young children, under 2, and the elderly, which is different from adults.
And there's a severe form.
Yes, crusted or Norwegian scabies, seen in immunocompromised or very elderly frail people. Massive numbers of mites, highly infectious, needs specialist management.
Treatment involves applying lotions.
Yes, products like malathion or permethrin. Crucially, the entire household and close contacts need treating at the same time, even if they don't have symptoms, to prevent reinfestation. And the itch can persist for weeks, even after the mites are dead, which is frustrating but important to know.
Finally, psoriasis, a chronic condition.
Yes, patients often self-manage flares. Characterized by red, scaly plaques, typically on elbows, knees, scalp. Can affect nails, too, causing pitting. It can have a significant psychological impact. Pharmacists can support patients, advise on emollients and specific scalp treatments, and recommend referral for severe flares or for a review.
Okay, let's quickly touch on COVID-19 and long COVID, as the guide includes this.
Yes. It notes COVID is now more endemic. Severe cases are less common due to immunity from infection and vaccination.
But long COVID is still a major issue.
Huge impact. Estimated 2 million people affected in the UK at the time the source was likely compiled. Higher prevalence noted in certain groups, those with pre-existing conditions, older age, deprivation, women, unvaccinated, those who were hospitalized initially.
And the symptoms are incredibly varied.
Massively varied. Debilitating fatigue, shortness of breath, brain fog, muscle aches, sleep problems, anxiety, palpitations. The list is very long.
What's the key advice for pharmacists here?
Referral. If patients have significant ongoing symptoms suggestive of long COVID, they should be encouraged to see their GP, even if they manage the acute phase at home.
Why is that referral important?
Because complications like lung or heart damage or postural hypotension, dizziness on standing can develop. Also, sometimes other underlying conditions might surface during recovery. The guide acknowledges patients might be reluctant to bother their GP.
And the pharmacist can encourage them.
Exactly. And offer simple, practical recovery tips like pacing yourself. Recognizing recovery is often up and down, not a straight line.
The case example mentioned helps differentiate.
Yes, assessing someone very common. But a key point, pregnant women with suspected UTIs must be referred due to the risk of the infection traveling up to the kidneys, which can be serious in pregnancy.
What are the classic UTI symptoms?
Frequency, needing to go often. Urgency, needing to go right now. Dysuria, pain or burning on peeing, feeling of incomplete emptying, cloudy or strong-smelling urine, nocturia, getting up at night to pee.
And there's specific advice about lower abdominal pain.
Yes, the Committee on Human Medicine, CHM, advises referral if someone has lower abdominal pain and dysuria, as this combination could suggest a kidney infection, pyelonephritis.
Urinary incontinence is also covered, specifically stress. Urinary incontinence, SUI.
Yes. Leakage with exertion, coughing, sneezing, laughing, exercising. Often linked to pregnancy, childbirth, or prolapse.
What should pharmacists ask about?
The impact on life, sex life, social activities, exercise. Does it affect sleep or cause low mood? Any constipation, which can worsen it. Any signs of prolapse. Reviewing medications is also important, as some can contribute.
The case example mentioned with the bladder operation history.
Yes, lady whose symptoms returned while on sulfanicin, a drug for overactive bladder, which has side effects that might have interfered with her pelvic floor exercises. It shows when standard management isn't working or there are complicating factors, referral back to the GP or specialist nurse is needed.
Period pain dysmenorrhea. Management starts with
sympathy and reassurance. It's common and can be really debilitating.
pain relief.
NSAIDs like ibuprofen are often very effective, providing good relief for over 70% of women. Paracetamol is an alternative or can be added on.
When does period pain need referral? What are the red flags?
Things like abnormal discharge or bleeding patterns, severe pain between periods if standard pain relief isn't working, pain associated with a late period raises the possibility of ectopic pregnancy, which is an emergency, or if there's a fever.
PMS symptoms are tricky.
Very tricky. Wide range, physical, psychological, behavioral. The guide notes there's debate about treatment effectiveness and often a high placebo response.
Heavy periods menorrhagia. Red flags for referral here.
Yes. Passing large clots or flooding, soaking through protection quickly, irregular periods, signs of anemia, tiredness, pale skin, known clotting disorders or being on anticoagulant medication, abnormal discharge, any bleeding between periods or after sex, pelvic pain, pain during intercourse, or a fever.
And if treatment doesn't help?
Referral is advised if OTC treatments like tranexamic acid haven't improved things after about 3 cycles. The guide also cautiously mentions endometrial cancer as a rare cause, listing risk factors, and advises against OTC tranexamic acid if that's suspected.
Menopause. Defined as
12 months without a period typically happens between 45 and 55. The time leading up to it is perimenopause.
common symptom.
Vasomotor symptoms, hot flushes, night sweats affect up to 80%, and urogenital symptoms affect about 40%. These can profoundly impact quality of life. Age varies. Too early menopause or premature ovarian insufficiency before 40 can happen.
What causes the urogenital symptoms?
Falling estrogen levels. This causes thinning and shrinking of tissues in the vagina and urinary tract. Leads to vaginal dryness, irritation, itching. Also, urinary frequency, more UTIs because the pH changes, loss of muscle tone contributing to incontinence, and often pain during intercourse, dyspareunia. Vaginal dryness tends to get worse over time post-menopause.
Management options.
Lifestyle changes can help some symptoms. Vaginal estrogen is highly effective for the vaginal and urinary symptoms specifically. Systemic HRT is another option to discuss with a clinician if symptoms are broader or more severe.
Sensitive topic.
Absolutely. The guide stresses using a private consultation area for these discussions. The case handled by the nurse practitioner shows the options, suggesting lubricants moisturizers first, then vaginal estrogen, possibly HRT if suitable.
Vaginal thrush candida infection. Common when?
Very common in women of childbearing age. Pregnancy and diabetes are predisposing factors. It's rare in young children and postmenopausal women, mainly because the vaginal pH is different, less acidic in those groups, making it harder for candida to thrive.
Can partners get symptoms?
Yes, men can get an irritating rash on the penis, rhinitis. It's important to treat both partners if symptomatic to prevent reinfection cycling back and forth.
Pain on peeing, dysuria, can happen with thrush.
Yes, it can be confused with a UTI. But remember the CHM advice, refer if there's lower abdominal pain plus dysuria.
There's an important rule about past STIs.
Yes, a specific UK CHM requirement. If the woman has a history of a previous sexually transmitted infection, she must be referred.
Why?
Because the symptoms could be misdiagnosed, or it could be a dual infection needing different treatment. The guide suggests tactfully asking something like, have you ever had anything like this before?
Self-care advice for thrush.
Use unperfumed soap substitutes externally, emollients if skin is irritated. Probiotics might help some women prone to recurrence, but evidence is mixed.
The Julie Parker case highlights
Recent antibiotic use is a major trigger for thrush. Also the importance of checking medication history and clarifying any swab results if the patient mentions them.
The guide also covers contraception services in pharmacy.
Yes, the Pharmacy Contraception Service, PCS, allows initiation and continuation of contraception, plus the progesterone-only pill, POP, specifically desogestrel, is available OTC now. And emergency hormonal contraception, EHC, of course.
Supplying contraception to under 16s involves ethical considerations?
Absolutely. Fraser guidelines are about assessing competency to consent. Pharmacists should encourage involving parents, but respect confidentiality if the young person is competent and doesn't want them told. Exploring why they don't want parents involved is important. PGDs might allow EHC supply for under 16s in some areas.
And pharmacists need to know about all methods.
Yes, vital for informed choice. Even if they can only supply certain ones, they need to be able to discuss the pros and cons of everything: implants, coils, injections, combined pill, etc.
POP side effects.
Menstrual changes are common, irregular bleeding, spotting, sometimes periods stop, acne, mood changes can occur. Desogestrel needs good timing, though it has a 12-hour window, unlike older POPs. Small increased risk of ovarian cysts, tiny potential increased breast cancer risk needs discussion.
When should someone seeking POP be referred?
If they'd prefer another method, if they might be pregnant, specific bleeding patterns, like heavy prolonged bleeding, suspected ectopic pregnancy history, or various medical conditions like uncontrolled high blood pressure, certain heart or liver diseases, history of specific cancers, or if taking interacting medicines.
EHC options.
Levonorgestrel, like Livanel, is OTC for 16++, ulipristal, LONA. The manufacturer doesn't state an age contraindication, but professional guidance, RPS, and local PGDs for under 16s apply.
The EHC case example shows the process.
Yes. Young woman, unprotected sex, 12, 18 hours ago. Check age, explain options, levonorgestrel OTC if 16+, ulipristal, potentially via PGD or other service, assess suitability, and crucially, use it as a chance to discuss regular contraception methods and where to access them.
Okay, quick look at men's health. Lower urinary tract symptoms, LUTS.
Key point. Refer if recent onset, less than 3 months.
And contraindications for OTC tamsulosin.
Yes. Things like previous prostate surgery, severe liver-kidney problems, certain heart issues, unstable diabetes, history of postural hypotension, dizziness on standing, or planned cataract surgery. GP assessment also needed if symptoms worsen, don't improve, or if using tadalafil frequently for ED.
Erectile dysfunction ED meds, available OTC.
Sildenafil and tadalafil, yes, for men over 18 after a consultation. But again, medical contraindications mean referral.
Like heart conditions.
Yes, recent heart attack or stroke, low or uncontrolled high blood pressure, unstable angina, serious irregular heartbeat, certain heart valve problems, all mean referral for a full assessment is needed.
The guide also covers older people, frailty, and falls prevention.
Important area. Age is a big risk factor for cardiovascular disease, 80% of deaths over 65. Men tend to develop it earlier.
Lifestyle advice is key.
Staying active, even short bursts. Muscle strength exercises, like using resistance bands at least twice a week.
Practical falls prevention tips.
Good footwear. well-fitting shoes, ideally lace-up or Velcro, not loose slippers, home safety grab rails, good lighting, removing trip hazards, and medicines review. Crucial for older adults often on multiple meds. Checking walking speed can be a simple indicator of frailty, and regular eye and hearing checks using aids if needed all contribute to reducing fall risk.
Eye and ear problems next. A general rule for eyes.
Significant pain plus a change in vision usually means urgent referral to GP or optometrist.
Pretty serious things.
Like uveitis, inflammation inside the eye, or glaucoma, high pressure. Need prompt attention.
Conjunctivitis red, sticky eye. Usually viral.
Most common type, yes. Often self-limiting, gets better on its own.
And the evidence for antibiotics drops.
Interestingly, the guide notes limited evidence that chloramphenicol drops are much better than placebo for most bacterial conjunctivitis because many cases resolve spontaneously anyway.
Warning about contact lenses.
Soft contact lens wearers shouldn't use drops with preservatives like benzalkonium chloride as it can build up in the lens and cause irritation. Preservative-free options are needed.
Dry eye.
Very common, especially in older women. Changes in tear quantity or quality cause that gritty, sore, burning feeling, maybe blurry vision. Management involves lid hygiene, artificial tears.
The Ellie case, child conjunctivitis.
Illustrates the GP perspective, limiting unnecessary antibiotics, managing parental expectations, explaining why drops might not be needed.
Earwax blockage.
Common cause of temporary deafness, discomfort. Management is usually ear drops to soften the wax, then maybe irrigation, syringing if needed. Ideally, the ear should be examined first.
Acute otitis media AOM middle ear infection.
Common in kids. Ear pain, fever, maybe hearing loss. Often viral and self-limiting, resolves in about a week when the eustachian tube clears.
But antibiotics are often prescribed.
Yes, the guide quotes a stat around 60% of kids with AOM in the UK get antibiotics, despite evidence showing they only really benefit specific cases.
Which cases?
Like children under 2 with infection in both ears, or any child with discharge suggesting a perforated eardrum. NICE specifically advises against decongestants or antihistamines for AOM symptoms.
Pharmacy First covers AOM too.
Yes, specific criteria allow antibiotic supply for, say, children under 18 with discharge after perforation, or those under 2 with severe symptoms in both ears lasting 3+ days, targeting those most likely to benefit.
Finally, some common childhood conditions. Chickenpox.
Itchy spots. Key advice is cutting nails short to reduce scratching and secondary infection risk. Calamine lotion for itching.
Measles.
Highly contagious. If suspected, avoid taking the child into clinics or A&E without phoning first to prevent spread. Risk of serious complications, hospitalization, even death in some cases. Vaccination is key prevention.
Scarlet fever.
Bacterial infection usually needs penicillin. Important public health point. Typically not infectious 24 hours after starting antibiotics. Guide advises on return to school nursery.
Fever in children, red flags.
Key things needing urgent medical help. Very young baby, under 3 months, specific high temperature thresholds, signs the child seems seriously unwell, floppy, unresponsive, changes in behavior, non-blanching rash, persistent vomiting, fits, difficulty feeding, signs of dehydration like fewer wet nappies.
Infantile colic.
That excessive, inconsolable crying in babies. Distressing for parents. Simedicone drops are sometimes tried, but the guide notes uncertain evidence and GP reluctance to prescribe. Other strategies, comforting, feeding techniques, parental support are important.
Nappy rash.
Irritant dermatitis. Prevention is key. Frequent changes, barrier creams. Can be complicated by candida, thrush. NHS expects OTC treatments to be used first line.
Ed likes.
Detection combing with a fine-toothed comb over wet, conditioned hair is the best way to diagnose. Treatment options include insecticides or physical methods, dimethicone lotions that suffocate lice. Wet combing itself can be effective if done meticulously.
Preventative products.
Not proven effective. The case example of the anxious mother highlights advising against these and focusing on regular detection combing.
Oral thrush in babies.
White patches inside the mouth, often caused by candida. Common in babies, also in immunocompromised people, steroid inhaler users, after antibiotics.
The case example shows the pharmacist's role.
Yes, baby on antibiotics. Pharmacist assesses diagnosis seems clear, can initiate treatment, like miconazole oral gel, following guidelines. Also need to consider if mom needs treatment for nipple thrush if breastfeeding, and advise on sterilizing bottles dummies.
Wow, okay. The guide even looks to the future. Pharmacogenomics.
Yes, using genetic information to potentially tailor drug therapy.
Is it happening routinely now?
The guide makes a crucial point here. Currently, the information from this testing that can clearly alter clinical decisions and reliably improve outcomes is actually quite limited for many drugs.
But people can buy tests.
Yes, consumers can purchase direct-to-consumer genetic tests, sometimes in pharmacies.
So the pharmacist's role right now is?
Providing balanced expert advice, explaining the potential place, the usefulness, the suitability, but really importantly, the limitations of these tests for individuals at this point in time.
And it's something being integrated into training.
Yes, NHS England intends to embed pharmacogenomics into pharmacy education and practice more formally, preparing for the future.
The clopidogrel example illustrates a specific use case.
Perfect example. Clopidogrel is an antiplatelet drug. Some people have a genetic variation in the CYP2C19 enzyme, meaning they don't convert enough of it to its active form.
Increasing their risk after a stroke?
Exactly. Increases their risk of another stroke, or TIA. Nice guidance from 2024 now recommends testing for this variation, but...
Only in specific circumstances.
Yes, specifically just after someone has had an acute stroke or TIA. That's when the potential benefit of knowing the result and possibly switching to a different drug is highest, and shared decision-making is feasible. The value of testing decreases significantly later on.
Right. That was a really comprehensive, deep dive into this guide. It just shows the incredible breadth of common conditions pharmacists deal with.
Absolutely. And the growing range of services they offer. They're increasingly positioned as accessible frontline healthcare providers.
From advising on those everyday coughs and colds,
to supporting people with managing long-term conditions, offering public health advice like vaccinations, smoking cessation, healthy living tips.
they really are a readily available resource, aren't they, for quick, informed advice and managing so many of those day-to-day health concerns.
You don't always need a GP appointment for minor ailments. Understanding more about these common conditions and, crucially, understanding the pharmacist's expanding role.
It empowers you, the listener.
Exactly. It empowers you to make more confident self-care decisions and know exactly when and where to seek help most effectively, using the right service at the right time.
So here's something to maybe think about as you go about your day. Given this increasing expertise and sheer accessibility of your local pharmacist,
Right there in your community.
how might you leverage that resource differently next time? Whether it's for a minor health issue for you or your family, or even getting support with managing a long-term condition. Something to consider.